Hello, patients, friends, and loved ones of our gynecologic oncology community. I'm Stefanie Ueda, one of the G1 oncologists here at UCSF. Being diagnosed with cancer is difficult. We do care about you and understand that this journey can be long and complicated, particularly in these times. With my colleagues today, we would like to celebrate all of our cancer survivors, but also know that many of you are still battling cancer or the repercussions of your cancer treatment. You are not alone. Cancer treatment involves many forms. Surgery, however, remains one of the mainstays, but surgery is not always the first step or appropriate choice for every patient. We at UCSF do strive to constantly evolve our surgical practice, and I wanted to highlight some of that today. Surgery, first and foremost, involves not only assessing the extent of the cancer, but also whether surgery is appropriate. Are patients fit for surgery? A number of factors come into play. When we meet you, we oftentimes are assessing, one, what is your overall performance status? Things that we look at include your other health conditions, your ability for exercise, which might be already decreased because of your cancer diagnosis. Do you have asthma, significant restrictive lung disease? Do you have obstructive sleep apnea where you snore and maybe have problems with your sleep? Do you have significant diabetes where your blood sugars put you more at risk for infection or poor wound healing? And then we always try to optimize, if able, to nutrition, surgical or physical frailty. We look at tobacco cessation, and even trying to limit alcohol use, because these all have major implications for surgical risk and ability to withstand anesthesia. One of the things we do in our clinic is something called a tug test. Maybe some of you do remember this. It's actually a very simple test where we have you sit and then walk a certain distance. And believe it or not, this is a surrogate for how fit a patient is. We know if the tug test is abnormally long, that patients do have higher risk for surgical morbidity. Other things that we have changed dramatically over the last 5 to 10 years is really looking to enhance our recovery after surgery, ERAS for short. This not only involves what happens at the time of surgery or thereafter, but really even when you first walk into the door into our hospital. We look at things like boost breeze and carbohydrate loading, which we know decreases perioperative nausea and infection. We do antiseptic skin prep to decrease bacteria and decrease the risk for infection. We do preemptive analgesics and anti-nausea medications. Intraoperatively, we really try to manage or restrict fluids because we know that if too much fluid is given, this can make the bowel more edematous or inflamed. It can actually lead to respiratory issues. So we try to minimize that to give the right resuscitation, we call it, during surgery. We do other things like give IV lidocaine infusions to help minimize pain. And then we make sure that the patient is warm enough, because we know that if a patient is cold, something called hypothermia, it also increases the risk for complications or infection. Postoperatively, we know that minimizing opioids decreases the risk for prolonged constipation, respiratory depression. We look at multimodal pain agents like higher doses of Tylenol, ibuprofen, and something called Neurontin for nerve pain. We move the catheter early. We try to get you up and moving around, even if it means it's difficult. And then we look at things like prophylactically giving blood thinners at low doses to decrease the risk for blood clots, which can be up to 20% in our cancer population. Surgery can be done in many ways. We always try to do it with the smallest incisions as possible, even though that doesn't mean the shortest surgery. And this is because this leads to decreased recovery time for the patient. This is one way of doing it, laparoscopy, where we're actually holding the camera and our instruments ourselves. This is usually a 2-surgeon procedure with a lead surgeon and an assistant surgeon. And then we use a robotic platform, also called the Da Vinci, where we're setting up the robot over the patient and then at a console nearby, moving the instruments. This allows for sometimes more 4-quadrant surgery or high-definition optics. Surgery can be done when we think the cancer is early. This involves not only sometimes removing the uterus, ovaries, and tubes, but also doing removal of any areas of concern for cancer, directed biopsies, lymph nodes. This is something called the omentum, a fatty apron that hangs off the colon, which can be involved in some types of uterine cancer, but also ovarian cancer. This is a suspicious implant on the bowel blood supply called the mesentery. These would be directed biopsies of what we think might be early stage cancer. But on final pathology, we might find that 20% actually have more disease spread. It's called upstaging. This can affect actually your treatment after surgery. We further know that removing all the lymph nodes for our cancer patients actually does not show to be helpful. Lymph nodes are throughout your body, but the ones we worry about most for most of our gynecologic cancer patients are in the pelvis or something called the periaortic region, which is lower their abdomen. We know that now we can actually inject a fluorescent dye that's seen with a special camera to actually see where the first lymph nodes that could be involved with cancer. We remove just these lymph nodes, and then there is special processing done by a pathologist. This is very highly effective in ruling out spread of cancer, but also has a high rate of being successful. This is further done in not only cervical and uterine cancer, but also in vulvar cancer, where we inject the primary tumor, and then we look for the first lymph nodes, usually on the same side as the tumor, where cancer can spread. These are usually often more in the groin, not in the pelvis or periaortic region. This minimized taking out more lymph nodes, which can lead up to, in 30% of patients, swelling in the legs called lymphedema. It also decreases the risk for infection and something called lymphoceles, because as you take out more lymph nodes, the other lymph nodes can always compensate. Unfortunately, we also have learned over the last decade, but more recently published in 3 years, that not all of our cancer surgeries can be done minimally invasive, not only because of the extent of the disease, but also it may affect prognosis. For early stage cervical cancer, surgery remains an option. It's called a radical hysterectomy. However, we now know that if a radical hysterectomy is done via a minimally invasive approach, it actually increases the risk for our cervical cancer patients in cancer recurrence and decreases their overall survival, meaning an increased risk for death. This has led to a practice change where we now do open radical hysterectomies in early stage cervical cancer. For advanced disease, unfortunately, for vulva and cervical cancer, surgery is not the mainstay. Sometimes we are not able to offer that. That's where chemotherapy and radiation became the primary forms of treatment, and surgery is reserved only for some select cases of recurrent disease. For uterine and ovarian cancer, surgery and chemotherapy go hand in hand, sometimes even radiation in select cases. And that's because for ovarian cancer in particular, disease may be more advanced where it's spread to other sites. And so then we have to balance starting with chemo or starting with surgery first, both to decrease the tumor burden either by surgery or by chemotherapy. So that's where there's this circular pattern of doing both for the first stage of for first presentation. We know there's a number of risk factors for why optimal surgery, where we're trying to get down to no visible disease, may not be possible. Older age, more upper abdominal disease, more comorbidities, which leads to a higher anesthesia risk score. These are all factors that lead to not only more postoperative complications, but a higher risk of having more disease left behind, which doesn't bode or help the patient at all. In select cases, surgery can be offered in the recurrent disease setting. Usually we reserve this for isolated disease in the pelvis, but also for isolated disease where we think it's resectable safely, potentially via a minimally invasive approach, or where there's less morbidity or risk for the patient. This might involve bowel surgery. This might involve removing a lymph node. So this involves a significant discussion with patients. There are now 2 out of 3 studies that show that this may be helpful in prognosis. Surgery, therefore, remains an important component of cancer treatment, particularly at the time of initial diagnosis. When disease recurs, surgery is reserved for select cases where there will be either prognostic benefit or potentially benefit on symptom control. I want to acknowledge all of you again in our gynecologic cancer community in these times where we cannot always celebrate or persevere together in person. Stay safe and know that we are thinking of you.